My name's David. I'm the antimicrobial pharmacist in Holles Street in the maternity hospital. I'm going to be talking to you about something quite different today to what we were talking about, just a different angle on the whole area of sepsis. So I'm going to talk about the Praxian labour study, which was conducted in Holles Street recently. This looks at the areas of maternal sepsis and the associated antibiotic usage that comes with that. So to give you a bit of a background, this graph shows the combined antibiotic consumption from the 3 Dublin maternity hospitals since 2008. As you can see, there's been a sharp increase since that time. This is due to a number of factors. As mentioned previously, reports in the UK and Ireland into the causes of maternal deaths highlighted sepsis as a direct leading cause of preventable death. They highlighted a poorer recognition of the signs of sepsis and poor management of sepsis as contributing factors. The report in Galway into the events by HICWA back in 2013 and the subsequent production of the IMUs, which is the Modified Obstetric Early Warning System, coincided with a sharp increase in antibiotic consumption in maternity services in Dublin. This was probably reflected across the rest of the country, I can imagine. So what are the consequences of this consumption? It's thought that changes to the newborn's microbiome early in life is directly linked to obesity, asthma and other childhood diseases. Of course, there's also the growing crisis of antimicrobial resistance. The more antibiotics we use, the worse the problem will get. The UK government has commissioned a report that estimates that by 2050, if we continue on our current path, deaths from previously treatable infections will outstrip cancer as a leading cause of death. So that's the situation we're facing into. Something needs to be done to control and possibly reduce antibiotic consumption in the maternity setting. To do this, we need to look at the area of pyrexia in labour. Now, pyrexia in labour accounts for around 40% of our antibiotic treatment indications in the National Maternity Hospital. But pyrexia presents a diagnostic challenge. It's the clinical hallmark of chorioamnionitis, which is infection of the fetal membranes and the amniotic fluid. But the signs of chorio can often be quite subtle and they're often masked by normal changes that occur during labour and during pregnancy. Very often, all that a clinician has to go on is a pyrexia in isolation. This is complicated by the fact that there are various non-infectious causes of pyrexia in labour. These range from physiological causes such as uterine contractions or even being a first-time mother. Iatrogenic causes are important. Prostaglandins to induce labour. Very importantly, epidural analgesia has been strongly linked with maternal pyrexia during labour. Now, it's not fully understood the mechanism of this interaction, but it's thought that there's inflammatory mediators that are released during labour somehow interplay with the epidural analgesia to produce this effect. Meta-analysis estimate the effect to be upwards of 3.3, but more recent studies have found the effect to be actually a lot stronger. It's thought that this effect is not dose-related, but it's related to certain patients are more prone to it than others. We also need to consider the obstetric SIRS criteria that we use. These differ to the ones used in a non-obstetric general population. In obstetrics, we use a temperature threshold of 38 degrees, whereas in the general population, we use 38.3. Now, this 38 degrees has been arrived on based on clinical consensus only. There doesn't appear to be much of an evidence base behind it. It's possible that this threshold could be a little bit too low. We don't know. We want to investigate that. A maternal heart rate greater than 100 beats per minute is a regular occurrence on a labour ward when a patient is in labour. However, this is also listed as an obstetric SIRS criteria as well. So this could have some impact on the way we manage our patients. A white cell count greater than 16.9 is listed as an obstetric SIRS criteria. However, there's a normal physiological leukocytosis during pregnancy, but particularly during labour. This is well documented and has been shown to be upwards as high as 25. The problem arises in that if 2 of these SIRS criteria are met, there is a lot of pressure on a clinician to perform a septic workup on the mother and also the infant. We wanted to find out, is this approach the best approach we can use? With this in mind, the infection control team in Holles Street conducted the Praxian labour study. We wanted to find out information on the causes and characteristics of peripartum maternal pyrexia. That's pyrexia in labour or within 4 hours of delivery, in order for us to assist us in decisions to safely start and stop antibiotics in mothers and infants. We chose the extra 4 hours after delivery window because we've observed a lot of our patients were spiking temperatures in that time. Now, we set 3 objectives for this: to determine the true rate of infection following peripartum pyrexia, to evaluate the diagnostic accuracy of the obstetric SIRS criteria and the CTG, the trace, for the identification of infection related to peripartum pyrexia. We also wanted to investigate various non-infectious risk factors for peripartum pyrexia, such as the epidural analgesia, using matching pairs of cases and controls. We took 175 peripartum pyrexia cases over a 5-month period. We matched each one individually at the time to the patient who delivered immediately afterwards, who didn't have apraxia. This controlling method meant that we controlled for the ambient temperature on the labour ward on that day, so that didn't act as a confounding factor. We included women who had, in the case group, peripartum pyrexia and a septic workup. Patients were excluded if they had signs of infection prior to labour, if they didn't go into labour, so if they had elective caesarean sections, or if they're immunocompromised. And we recorded a huge volume of data on these patients. So we had 175 pyrexia cases with 175 septic workups. These consisted of a full blood count, blood culture, urine sample, vaginal swab. Some patients had a rectal swab and some had a placental swab. We used a combination of histological and microbiological data to see who had infections and who didn't. You had a confirmed infection if there was a bloodstream infection, a confirmed UTI, a significant pathogen in the placental swab, or if there was possible infection due to growth of organisms at a non-sterile site, such as a vaginal or rectal swab. We then asked the histopathologist in the hospital to examine the placentas to see if there were signs of chorioamnionitis present. If there was signs of chorioamnionitis present, this was deemed to be confirmed infection as well. Patients had no infections if there was no microbiological evidence of infection at any swabs or cultures, or if there was colonization at a non-sterile site, so there was growth of microorganisms in the vaginal swab, but there was no presence of chorioamnionitis histologically. Maternal demographics were similar between cases and controls based on a number of factors. There was no cases of severe sepsis in either group, which means that any recommendations that come out of this study can only apply to patients who don't have severe sepsis. There was twice as many first-time mothers in the case group compared to the control group, so this may have skewed our figures somewhat. The case group consisted almost entirely of term deliveries. This occurred because we excluded patients who had signs of infection prior to labour, so we would have left out a lot of preterm labourers who were clearly unwell and went into preterm labour that is due to infection. Again, any recommendations that come from this study can only apply to patients who delivered at term. In terms of delivery outcomes between the cases and controls, the pyrexia cases had far more complicated delivery outcomes. There were far longer labour durations, more instrumental deliveries, more emergency caesarean sections, postpartum hemorrhages, episiotomies. For the neonates, there was far more admission to the NICU in the first, immediately after birth. APGAR scores were lower at 1 minute, which is a reflection of the higher emergency caesarean section rate, but they were similar at 5 minutes. So the neonatal outcomes were broadly similar. When we look at the breakdown of what stage of labour the pyrexias occurred in, we see that a big proportion occurred in the first stage of labour, from the time that onset of labour to full dilatation. A smaller proportion occurred from the time the pushing began to delivery of the baby to delivery of the placenta. Surprisingly, a large amount occurred in the 4 hours postnatal. We didn't think it would be as high as this, so this shows how much of a burden this is in terms of peripartum pyrexia. If you spiked in the 4 hours postnatally, this occurred on average after 1 hour and 42 minutes. No patient spiked outside 3.5 hours. So our first objective was to find out the confirmed infection rate. We found that over 2/3 of our patients had absolutely no evidence of infection or colonization. A further 14.3% were colonized at a non-sterile site. Only 17% of our patients had confirmed infections. So while this figure is low, it's actually higher than what we thought it would be. We thought this would be a bit lower than that. It's not something we think we can ignore. When you look at the breakdown of those infections, there were 4 bloodstream infections. These are 3 maternal and 1 neonatal. There was very few UTIs. There was very few microbiologically confirmed chorios. The majority of these were histologically confirmed chorioamnionitis. So this was new information to us. We wouldn't normally do this as part of a septic workup. So this provided some added value to the study. To put this into perspective, if you had 100 women with peripartum pyrexia, this is how many would have no evidence of infection or colonization. This would be all, the ones in yellow would be colonized and the ones in red would have infection. So your confirmed infection rate overall was 17%. But if you do pyrexia during labour, your confirmed infection rate was 22%. If it was in the 4 hours postnatal, it was 10.7%. We had 4 bloodstream infections, all occurred in patients with pyrexias during labour. This led us to believe that maybe the patients who spike in the immediate 4 hours postnatally, their temperature spikes might be of less significance clinically. That was our first objective. The second objective was to evaluate the diagnostic accuracy of the obstetric SIRS criteria. We observed baseline maternal vital signs between cases and controls before there were signs of infection, and we found that there was no statistical difference between cases and controls in terms of their baseline maternal vital signs. When we look at the distribution of the maximum temperatures that were recorded in the case group, we can see that the vast majority of them occurred in patients with a temperature spike of 38 to 38.2. So 38.3, there was a lot less after that. But 60% of our confirmed infections occurred in this group that had a maximum temperature spike of less than 38.3. So this does provide us with some validation of the use of a temperature threshold of 38 degrees as a marker of infection related to peripartum pyrexia. The diagnostic accuracy of the obstetric SIRS criteria was evaluated using receiver operator curves, or ROC curves. This is a measure of the sensitivity versus the specificity of the test, and it's used to aid evaluation of diagnostic tests. A test that is of no use, same as flipping a coin, would cross this blue line here. It would be a worthless test. An excellent test would be similar to this yellow line here. All of our cases had one SIRS criteria, which was a temperature greater than 38 degrees. When you combine that, and if you give them two SIRS criteria, temperature greater than 38 plus heart rate greater than 100 beats per minute, which would be used in obstetrics, this came out across the blue line and wasn't of much value as a diagnostic test. The sensitivity and specificity were roughly around 50-50. Similarly, with the white cell count greater than 16.9, when you combine that with a temperature of 38, again, it crossed this blue line here and was the same as flipping a coin, so it wasn't of much use to us during labour as a marker of infection. Almost barely any of our patients were tachypnic or hypotensive, so the sensitivity wasn't great there, but again, it wasn't of much use to us during labour. So a non-reassuring CTG resulting in a change of obstetric management was strongly associated with peripartum pyrexia. So the patients who had the non-reassuring CTGs, they were probably the ones who are more likely to have temperatures. We thought then maybe these patients who have non-reassuring CTGs would have a higher rate of infection. If you had a normal CTG, you had a 16.3% infection rate. If you had a non-reassuring CTG, it was 18.2%. So again, it didn't provide us with much information to work on. So we know what we don't know, but what we don't know is a lot. That was our second objective. Third objective was to look at the different risk factors for peripartum pyrexia. Now don't get bogged down by this slide. I put this up to show you just how many risk factors we looked at for our cases and controls. In isolation, all of these up the top here appeared as significantly associated with peripartum pyrexia. Epidural up there, 25 odds ratio, which seems enormous. But when we did conditional logistic regression on this, we found that we controlled for confounding variables and only two factors emerged as being independently associated with peripartum pyrexia. It's epidural analgesia, so odds ratio of nearly 11, which is a very significant association, and nulliparity. If you're a first-time mother, this is significantly associated as well. When we drill down into the epidural, we found that patients who had peripartum pyrexia had a longer duration of epidural exposure, but they also had a longer duration of labour, so we don't know if it was due to the labour or the duration of exposure. There was no difference in the volume of epidural fluid given between cases and controls. This is in line with the literature that predicts that there's no dose-response effect. Instead, it's related to patients. Certain specific patients will have this effect. There was no difference in the number of epidural top-ups between cases and controls. There was no difference in the initial block combination between cases and controls. If you had an epidural and then a temperature spike, this occurred after an average of 6 hours, which is in line with the literature. The range is 1 hour to up to 13 hours, so the effect could potentially last for up to 13 hours. We then thought that patients who had temperature spikes in the absence of an epidural would have a much higher rate of infection, and that these would be more clinically significant. But what we found was the infection rate was similar whether you had an epidural or not and you had your pyrexia. In fact, all 4 of our bloodstream infections occurred in patients who had an epidural and then a pyrexia. So if we took the approach that this is epidural fever, we're not going to give antibiotics to this patient, we would have missed all 4 bloodstream infections. So clearly we think that's not an approach that we can take. To conclude, the infection rate is around 17% if you've peripartum pyrexia, so it's low, but it's not insignificant. We don't think it's something we can ignore. If you had your pyrexia within 4 hours of delivery, this was associated with a lower rate of infection. We need new criteria to identify patients at risk of maternal sepsis around the time of labour. Whether we need it for pregnancy or not is not being dealt with here, but around the time of labour, we need to change our approach. This low rate of infection, combined with the poor diagnostic accuracy of obstetric SIRS criteria around the time of labour, mean that we need more sensitive and specific markers of maternal sepsis. Otherwise, we're going to see an overuse of antibiotics. This study does provide some validation for the use of a 38-degree temperature threshold as a marker of infection around the time of labour. Epidural analgesia is strongly associated with peripartum pyrexia. The effect does not seem to be dose-related, but it could possibly be patient-specific. The challenge for us now is to see, can we identify in advance which patients are likely to spike these temperatures so we can maybe change our management at that point. It's thought that inflammatory cytokines, one of them in particular IL-6, is involved in this process, so research is being directed at this area at present. We do think it would be unsafe to withhold antibiotic therapy for patients who we think have epidural fever. Recommendations. So for patients with Praxian in labour, just over 1 in 5 had infections. We're now recommending shorter courses of antibiotics in these patients. So if you delivered at term with no signs of severe sepsis and no signs of infection prior to labour, we're still saying do the septic workup, but stop automatically at 48 hours unless mother and or baby's blood culture is positive and as long as mother and baby are both clinically well. For patients with Praxias within 4 hours of delivery, just over 1 in 10 had infections. If you delivered at term with no signs of severe sepsis, no signs of infection prior to or during labour, we're now recommending to monitor for longer. So the IMU's observation needs to be taken from before they're discharged from the labour ward. We're now recommending to push that out to just prior to when they're going. So this gives the patient more time to cool off for the effect of the epidural and the effect of labour to wear off. And then if they do spike a temperature, we're then saying to wait a further 60 minutes before. You can wait if you're clinically worried about the patient, don't wait. Go ahead and start your septic workup. But if you think the patient is fine, it's just a pyrexia, it's related to the labour, you can wait for up to 60 minutes before starting the septic workup. Again, stop antibiotics at 48 hours if blood culture is negative and mother and infant are clinically well. So all the sepsis bundles that we use and the care pathways and the screening tools that we use need to be balanced against the risk of antimicrobial resistance. If we don't have effective antibiotics to treat our infections, then all of our efforts to treat sepsis are going to be in vain in the long run. And that's it. This project was carried out as part of a research master's in clinical pharmacy in Queen's University Belfast. I'd like to thank all these people for their involvement in the study. It was a truly multidisciplinary effort and couldn't have been done without a huge team of people. And thank you for listening.